Hello, everybody, and welcome to another lung talk with your host, Alexander Grachewin from HRN, where we provide pulmonary and cardiac rehabilitation, of course, virtually. And there's something else I want to kind of address here before I go into topics or anything like that. So participating in a pulmonary rehab program, when anybody, not just with HRN, but with anybody out there that's wanting to go into pulmonary rehab, okay, itself, where we basically transform the lungs to work better for you, all right? So if your inability to walk very far, well, we got you covered. And but when you go look in for a pulmonary rehab program, you want to make sure that the pulmonary rehab program is focused in lung health, okay, not just walking. It's specifically stating how much exercise are we doing for lung improvement itself? How much respiratory muscle training are we doing? Are we doing any respiratory muscle training? The reason why I state that or say that is for a very good reason, and that is a large, and I very mean above 95%. If not a lot higher than that. About more than 95% of the rehab facilities in the United States don't cover respiratory muscle training or do respiratory muscle training itself. If you went to a pulmonary rehab and they put you on a treadmill or a bike, and that's all they're really doing, they're giving you medications, they're assisting you with walking, well, that's great. But that's not pulmonary rehab. Pulmonary rehab should also focus on improving lung abilities, the lung capacities, lung improvement scores. We're looking at FEV/FEC, forced vital capacity, to improve the lung capacity, to improve the lung volumes, improve the overall lung itself. When somebody's at a very end-stage COPD, bringing them back up. That's a pulmonary rehab you want to go to. That's a pulmonary rehab you want to focus on. Hi, how you doing, Michelle? Hi, Pamela. Hi, everybody. Hi, Rita. But yeah, that's what you really want to focus on. When you want to go into a pulmonary rehab, the big takeaway is which programs out there actually do respiratory muscle training. Well, HRN specifically works on respiratory muscle training. That's another reason why you're looking at us as a very high-end level, meaning that you'll get a lot of improvements with HRN, and that's why it's fairly widely known now. But anyways, as I go in further, if you're trying to join into a pulmonary rehab, just do yourself a favor and just do some research. Research and make sure the doctor that wants you to join into a program, and that program is a successful program. Looking into that program, looking at their outcomes. How many people have benefited from the rehab program itself? What do they benefit with? Okay, when they went into pulmonary rehab, do they improve their lung health? Do they wean off oxygen? Are they walking further? These are questions that you should be asking, to your healthcare provider that wants you to go into a rehab program. Because you are the boss and you get to choose that, okay, that rehab program, doc, does that do respiratory muscle training? I don't know. That's something you have to ask them. If that doctor doesn't know that question, most the chances are is they probably just don't know that program, or the chances are they don't do that. Okay, they don't do that specifically. Anyways, as I go over some of the improvements that a lot of patients are making, of course, with this. I just want to address Mary Lynn. I'm not going to mention the last name, but first name, last initial is G. So Mary Lynn G walked 100 feet initially, just an initial. Okay, so her first time walking with us was 100 feet. After about a month and a half in, she's actually able to go 2,200 feet on her 6-minute walk test. So congratulate Mary Lynn. That's Mary Lynn G. Congratulations on walking a heck of a lot further than you have. And of course, that's what good pulmonary rehab program. That's what a good pulmonary rehab program should do for you. I have another patient. That's actually my patient. That walked 1,900 feet. That's 1,900 feet when Gene could not walk much further. Volume is up quite substantially, and yeah, we're looking pretty darn decent. There's no doubt about that. Looking pretty darn decent with each and every single one of these patients that are getting their life back, really. So, if I haven't done so, if you have any specific questions or anything like that that you want to address with me, please don't hesitate to write a comment or question or anything on the comment section of this, and I'll be happy to go over any questions, okay, as they come up on here. All right, as they come up on here. So if you come up, like if it's later on, I'll probably respond later on. But if you want a response right now, you just have to join into our live feeds. We call our Facebook Lives, which also go to YouTube and other social media places, of course. I'm a clinician. I'm under the Maryland Board of Physicians as a respiratory care practitioner. I've been doing this for more than a decade. And yeah, I'm a very, very good clinician when it comes to pulmonary rehabilitation, as a lot of people know that. A lot, actually. Anyways, let's go ahead and dive in to our lives. First, all right, I'm going to throw a question out. You're going to give me the best comment or a best answer to the question, okay? You're going to give me, this is a questions and answer type of thing. All right, first question, and you're going to give me the best possible answer. Somebody who doesn't work out a lot, okay, that doesn't work out a lot, but gets very breathless very quickly, okay? The person has end-stage lung disease. All right, and I'm not specifically stating what type of lung disease. You can say it's interstitial, or you can say it's obstructive, doesn't matter. The patient has end-stage lung disease and can only walk let's say 20 feet. The patient can only walk 20 feet, and the patient gets out of breath very, very quickly. What are the reasons why the person gets out of breath? I know it's a very open-ended question, isn't it? Why does the person get out of breath? First off, what causes the out of breath? Does anybody know that answer? What causes the out of breath? It's a simple question. It's not a loaded question, but what causes out of breath? So you could say dyspnea, shortness of breath, but that's just describing carbon dioxide. Pamela, very good. Carbon dioxide is the culprit that causes the out-of-breath feeling, sensation that you feel. So when out of shape, Gail, very good. That was the one thing I was looking for. Being out of shape. Is it possible somebody can just be out of shape, and even though they have lung disease, they're not really out of breath with a lung disease? Could they just be out of shape? Yes, there are people like that. There are people that have very severe lung disease where the problem with COPD, or lung disease in general, but really the problem with COPD is that you can't exhale as fully as you did before. Meaning before you were able to breathe in, exhale easily, CO2 came out very easily. There was nothing being trapped in your lungs. Well, as you gain more and more, as your disease gets more and more severe because you're not doing anything about it, because you're not working on it, it's obviously going to get worse. Right? And the worse it gets, the more severe my lung disease is. And of course, the longer I need to exhale. Okay? Think about that. The longer I need to exhale. All right. So when somebody with very advanced lung disease, before they were breathing in, 1 second, they only needed 1 second to breathe in air to get oxygen in. And then when they exhale, they got rid of enough CO2, which is about 1.5 seconds to about 2 seconds on exhale timing. That's for a normal person. When somebody has very severe lung disease, their inhalation will still stay the same, about 1 second. But on their exhale, they might need 3 to 4 seconds to exhale all the CO2 out because there's trapped air, because there's CO2 that's trapped in the lungs because of obstruction. Right? And that person is chronically obstructed. So when somebody's exercising, when they have severe lung disease, they might need longer exhalation timing. Okay? So if we keep that problem going, that problem will stay consistent. Meaning we always breathe in a second, we're only exhaling a lot, we're not getting rid of a lot, so we tend to exhale a lot longer. When do we fix that? When you're in the program, we work with you of gaining your lung abilities. We educate you on your lung, the disease itself. But what we try to do, not really try, we actually just do it. What we try to do is get the lungs to be more normal. Gain them to be more normal. So if there is an obstruction, we try to fix that obstruction problem. If there is if you needed more time to exhale, we'll try to speed that process up where inhalation and exhalation are just as good as it used to be, maybe a little bit longer, maybe like a half a second longer. Where instead of you needing 4 seconds to exhale your exhale volumes, you probably only need like 2.5 seconds instead of 2 seconds. So we try to get you back to where that is. And you live a normal, long life. You don't have the problem with all this work of breathing because you're out of shape or maybe your disease is very well unmanaged. But yeah, that's the gist of it. Exercise is the best way to help with shortness of breath. Exercise, but what kind of exercise, Michelle? If I just exercise, is that going to increase my lung function? Is that going to decrease my work of breathing? A lot of people would think yes, but that doesn't, not really, no. If you're working on your legs, look, this is the reason why we are the best ones out there, okay? This is the reason why we're the best ones out there. We don't just work on our legs to get people better. Because if we just did that, we would be just like everybody else with 11% success rate. We're at 98% successful with all of our patients. That's the highest in the world. It's the highest in the world because we incorporate respiratory muscle training exercises that decrease work of breathing. Everybody else is putting somebody on a bike or on a treadmill, and as soon as their oxygen drops, they stop them. Or that's what they should be doing, right? They stop them, though, because their oxygen is going down. We take things to a different level. Okay, when we see the oxygen drop, we want to know if it's correct. We want to know by checking one finger on one hand, checking on another hand. We want to check blood pressure the same way. We want to look at, is it your oxygen that's dropping? Is it your CO2? Is it bad circulation? We don't look at it as, okay, the person's oxygen dropping, then that's it. We don't ever do that. Or else we would be like everybody else. Okay, we're not like anybody else. We're very successful. And we're a lot of people, and I mean a lot of people, doctors to patients, always ask us to write a book to help be the blueprint of any future or current pulmonary rehab programs in the United States, if not the world. There has to be a reason behind that. So exercise in general doesn't necessarily increase lung volumes and lung functions. It might increase a little bit, but when you specifically work on respiratory muscle training with those other exercises, then of course you will decrease the work of breathing with any type of exercise that you want to endure. But we also have to understand that exercises, the work of breathing associated with those exercises, are a consequence to that exercise. So if I'm walking, I should automatically know that even if I don't have lung disease, my work of breathing is going to slightly increase, not become unmanageable. That's why a lot of people think a 50-50. If they're out of breath, it's their lung disease and they should stop like that, if they're out of breath. No, how out of breath are you? Can you keep going? Are you getting completely out of breath? Why did you let yourself become completely out of breath? Why didn't you slow down, pick up the respiratory rate a little bit more? Things like that. We don't look at it as 50-50. We look at it as, more like an 80-20. And what I mean by that, I know that sounds really difficult to understand. All it means is that when a patient sees that they're out of breath, when a person sees that they're out of breath, they're thinking I should just stop. Well, if I said, how out of breath are you? And I was talking to Jim or Carolyn or Michelle or Kenny, and I said, how out of breath are you? Well, I'm at a 5 on my work of breathing. Well, then you can keep going. Yeah, I can keep going. It's different when you look at it like that versus are you winded? Yes. Are you completely winded? No. different when you quantify it. That's why in here we quantify our work of breathing. When somebody's working out, they're like, Alex, I'm out of breath. How out of breath are you? I'm at a 4. Well, that's not completely out of breath. No, I can still talk. I'm still able to do things, that you can keep going. If somebody else was in my place governing a respiratory patient, let's say, then that person said, how out of breath are you? You know, how out of breath are you? And they say, well, I'm winded. Then that person might say, stop. And what is that leaving you with? At the very end, I'm still bad. That's your mentality. Okay, it's always getting worse. Is it ever going to improve? Those are the things and the conversation I'm kind of having with myself. Anytime a clinician that's supposed to know more than me is saying, we got to stop because your oxygen dropped. Every time you come in, your oxygen drops, you got to stop. Oxygen drops, you got to stop. Your work of breathing is going up, you got to stop. I've never, ever, in any physical activity, never rendered a little work of breathing. I mean, so why are all these clinicians stopping? Because that's their protocol. In here, we would stop you if we see that it's that somebody is unmanageable completely with their work of breathing. And a lot of people find that's them. Oh, every time I stand up, I get out of breath. We'll stand up right now. Well, it only happens when certain things happen. See, now we're getting into the nitty-gritty. We're going into the details of it. So you get out of breath, you just stop? Yeah. Well, how about this? Let's go ahead and work out. When your work of breathing starts to climb, just raise your hand up. Don't even speak. Just raise your hand up in class. Your work of breathing is going a little bit unmanageable. Okay, and then I'm going to help you while you're riding your bike or while you're walking in place with me. While you're exercising, I'm going to coach you. It's different. You have a better outcome, better look. All right, the clinician isn't telling me to stop, so I don't feel bad now. The clinician is just telling me to slow down, pick up my breathing a little bit better, try not to stop. Do you see how the work itself is very different than another place, possibly? Yes, of course. Every pulmonary rehab program is not equal to each other. Their protocols might be very different from anybody else's. Just like our protocols are different. We don't have people passing out in our classes. People don't pass out in our classes. We keep everybody safe. But we don't stop them. Think about that for a second. Our rate of losing people or people like getting too out of breath, we would have the worst outcomes ever. We wouldn't have 5-star Google reviews. We would have the poorest ones. Or really not as good. If all we did was render people out of breath, and because our protocol is different, our protocol is fantastic. Okay? Stanford, Johns Hopkins, Harvard, Cornell, Temple, VCU. I just faxed on how many 460 something providers the last couple days. We have so many facilities that are top-ranked facilities. If they didn't think we were up to par, they would never use us. We are way better than everyone else. And a lot of those places have their own facility. We are that good. That's how good HRN is. That's how fantastic it is. But you have to put in the work. You got to put in the work. Yes, intercostal muscles do get weak. Respiratory muscle training it has to be all the way up. I'm responding to Rita as well as Michelle and Kenny. So, all right. All right, let's talk about interstitial lung disease. Types and causes. Introduce the broad categories of interstitial lung disease. We're going to focus on idiopathic, pulmonary fibrosis, sarcoidosis, and etiologies. We're also going to look at diagnostic approaches and management strategies. First, understand there are two different types with a lot of underlying categories in them. Two different types of lung disease. You have an obstructive, technically three. Technically, I'll explain the third one. You have two different lung diseases. You have obstructive lung disease, which is our 5 types. right? Obstructive. What are the 5 obstructive? You have asthma, cystic fibrosis, bronchiectasis, asthma, emphysema, chronic bronchitis. You have 5 types. Interstitial lung disease, there's a large amount of different types of interstitial lung disease. This can be any types of caligous fibers that are overabundant inside the lungs. So fibrotic lungs. When the lungs repair itself, it causes fibers that repair those tissues. So when there's let's say there's emphysema, or maybe there's another problem, the lungs will try to repair. Well, too much repairing will cause the lungs to solidify, and in this case, cause interstitial lung diseases. But so there's 2 different types. We have restrictive and obstructive. The third one is a mixture of both of those, where you have a combination of restrictive and obstructive lung disease both together. Okay, if somebody stops smoking, let's talk about this. When somebody stops smoking, and let's say they've been smoking at least 1 pack a day for at least 10 years, I would like to say more like 20, but let's just say 10 years. When the person stops smoking, what does the lung start to do? You have your cilia that starts moving. That's the air follicles inside your airways. They'll start moving. They're not paralyzed anymore. So you start producing a lot more congestion as soon as you finish. As soon as you stop smoking, you might produce a lot more congestion because the lung's trying to clean itself out now. Okay. Also, what a lot of people don't know is once you stop smoking, all the damage that was done from that smoking is now going to be repaired. And in the course of months, you will find that your lungs feel a little bit stiff. And that's because all the repairing from all that exposure of smoke inhalation. So is it normal when you stop smoking produce a little bit more congestion than normal for the first few months? Yes, absolutely. Is it normal to have an increase in tightness in your chest? Not because of inflammation, but because of the scarring? Yes, absolutely. So what should somebody do when they have tightness of chest and they report to the doctor? Doctor doesn't see the eosinophils are high, like pollen and other environmental exposures causing the tightness. Looks like the tightness is caused by your lung parenchyma being, the pink tissue, being repaired. So when they're being repaired, yes, the first few months your chest could feel a little tightness. But what somebody should do as soon as they stop smoking is join into a pulmonary rehab program and go into respiratory muscle training, because we're going to automatically do that, at least at HRN. Anybody else, they probably won't do it at all, as we saw that over 95% of the rehab facilities do not, I'm going to say this again, do not do respiratory muscle training. Over 95%. Over 95%. If you didn't have a respiratory muscle training, you weren't doing it 6 times a day, 10 minutes each, you weren't doing it. Okay? So you want to do a pulmonary rehab, you probably got a little out of it, but you didn't get I'm sure you didn't get a lot out of it. You may feel like you got a lot out of it, but you probably didn't realize that you didn't. And how do you know? Is that you still have the same problem as you did as you went in as you came out. That's how you know. Pulmonary rehab is supposed to change your life. It's supposed to give you the ability to walk further, more confidence to go outside, to walk around, go jogging again, go hiking, do things that you couldn't do for years. I mentioned the person that can only walk 100 feet and now is doing 2,200 feet. That's not just one person. You have a tremendous amount of patients in this program that do that go way above than what they did initially. But that's what you should be looking forward to. When you look at a high success rate like HRN, that's another reason why we have our live feeds. It's because we do a really good job with our pulmonary rehab patients. And of course all the doctors and everybody's all happy with us, patients are happy, but needless to say, that's the way it is. So when we look at obstructive and restrictive lung disease, respiratory muscle training doesn't really change very much with those. You're still doing 6 times 8 minutes each. Of course, when doing respiratory muscle training, you sit up straight, then you do a side and side, and you do the elbows on the knees. So you do you only really need one of those, but I give a variety of exercises. Because if the reason for the variety is it gives muscles don't like to be bored. If I lift one muscle for my biceps, what's wrong with lifting it sideways? What's wrong with doing hammers to work out my triceps? No, you're just adding variety to it. It's great for the muscles. Muscles love variety. They don't like just to lift and that's it, even though that's their job. But how you lift it. You know, when somebody's exercising, if you lift slower, you'll gain more muscle mass than if you move faster. That's an actual fact. Yeah, because you're keeping tension, those muscle tension, you're keeping that tension going, making it, just lasting longer on a repetition than it's slower. It's called tension time, okay, or muscle tension time. I smoked for 40 years, and I have been in your program since September. I'm at 3,700 on my incentive spirometer. 3,700. My goodness, Kenny, that's fantastic. But that's what a pulmonary rehab program should do. You should be able to wean off oxygen, walk further, as long as the heart's not compromised. But we don't cure anybody. I had a conversation with somebody that I guess thought that maybe some of the medical people out there already have a cure to COPD or they have a cure to things. Guys, if there was a cure to something, I would be mentioning it a lot in here. I'm a good person. I know I'm a good person. I'm a good clinician. I'm a very good clinician. Okay? I'm telling you facts. There is no cure. Not yet, but there is no cure. But if you were to look at a cure, our rehab program would be the closest thing to it. Oh, I'm not kidding. If there was a cure, it would be the closest thing to it. It might not be a pill, everybody. It might, the cure to something like the cure to fatigue is good old-fashioned exercise. So what's wrong with the possible cure to COPD? Could be a form of exercise. It could be. So if there was a cure, it would be the closest thing to it. Pulmonary rehab specifically would be the closest cure to it, as long as it's done correctly, of course. All right. Do we have any questions? Guys, bring some questions up. You can ask any types of questions you like. I see there's a lot of people watching me, so please don't hesitate. Go ahead and write up any questions you like. I'll be more than happy to go over these. All right. All right, let's look at the action of breathing. Action of breathing. The action of breathing is to get air into the lungs. At that point, the oxygen in the air gets pulled in to the blood. There's actually a lot more gases than that, but we're talking about inert gases, but we can talk about that later on. So you breathe in air, oxygen goes into your lungs, right? It goes into your blood. Then at that point, it has to do what? You got the air inside your lungs, it goes to your blood. Where does it go to first? Your heart. Okay. Now, if oxygen is in your blood, does that mean your tissues are getting oxygen? Supposedly, that's what's supposed to happen, because you wouldn't be alive if that wasn't happening. But there are times where blood pressure is a little bit too low, and oxygen has a hard time getting to transport past the blood into the tissue. Somebody went to the emergency room, and they were completely cyanotic, but their oxygen was 100%. They were completely cyanotic. They were blue in the lips, gums, everything. Their hands, extremities were all blue. But their oxygen was 100%. What do you think the problem might have been? Anybody? You try to win those lungs inside Michelle. So hey, remember the question. Well, what do you think that might be? Recommend any supplements for the lungs. Mama, if I recall, Mama Leda, where was that at? I have a wicked memory. So I can remember people even first introducing with them years ago, and I can still remember them. I just have a wicked memory. But Mama, if I recall, you're in a different country, and if I recall, unless your name has the same name. Anyways, I wish there was a supplement or something. There's NAC. But there's nothing that you can eat or digest. There's nothing that you can take to fix the problems with your shortness of breath. Now, of course, we can alleviate some of those with some medications to alleviate some of the symptoms, but it won't relieve all the symptoms. The only way to actually work the lungs out so you can be, completely independent, not depending on everything, is to actually exercise, to be in a pulmonary rehab program itself. Pneumothorax cyanosis. Okay, so somebody comes in with 100% oxygen. They're blue in the face. They're blue in the extremities. What do you think the problem is? Could be low blood pressure, very, very low blood pressure, because what causes the oxygen to get transported past the oxygen is in your blood. How does it get into the tissues? It doesn't just fly there, or anything can fly there. It has to be selective. It's only that's what we call semi-impermeable. It has to be selective. Because if it allows anything, then blood can hemorrhage through there. So it's not going to allow blood to go through it. It's not going to allow fluids to go into it, not some of them. We're looking at gases. So the gases are only transported past the membranes through blood pressure, systolic and diastolic. If the pressures are too low, the oxygen in the blood will stay high. It's not being depleted. Does that look good to you? So you see somebody completely cyanotic, the oxygen is in their blood, but it's not going into their tissues. That could be due to low blood pressure, of course. Also, your pulse ox has never a day in its life has ever measured oxygen. Never. Your pulse ox has never, ever measured oxygen. Did anybody ever know that? Does anybody ever know that? Did anybody know that? Pulse ox doesn't measure oxygen. It never has ever measured oxygen. And I'm telling you, as a very well experienced clinician in pulmonary rehab, pulse oximeters don't measure oxygen. It assumes oxygen. What if you have carbon monoxide? If you take your pulse oximeter and you turn it on and you wave it in the air like you just don't care, right? Is it going to measure the oxygen in the room? No. It says the finger is out, it shuts right back off. It shuts right back off. Because it's not measuring oxygen, it's assuming oxygen. What if the assumption, the pulse ox thought it was oxygen, it could have been carbon monoxide? We get that a lot. People come in with carbon monoxide poisoning, not dioxide, monoxide. It's compound 1. They come into the emergency room completely blue in the lips, and they're cyanotic. Their oxygen is reading like 100%. We do an arterial blood gas. They go and we analyze it through the blood gas analyzer, and it's reading like 210. It's like, that's not oxygen, actually. Could be, but it's not. It's actually carbon monoxide. It's binding on so heavily onto those red blood cells and the hemoglobin on the red blood cells that the pulse ox is picking up the gas on there, but it's thinking it's oxygen when it's actually carbon monoxide. And we can tell that because the high heart rate, it's not getting rid of it. It's staying in the system. The body wants to try to get rid of it to replace it with oxygen, but it's binding on super, super tight. There's a lot of reasons. Not just those two. There's a lot of reasons why somebody can be completely cyanotic. Their oxygen is looking 100%, because the blood is keeping the oxygen. It's not releasing the oxygen into the tissues. People think if there's oxygen in my blood, I'm good. They don't realize there's other things to look at. You know, if you are feeling very fatigued, you're lightheaded, dizzy, blurry vision, those are signs and symptoms of low oxygen. You see your pulse oxygen is nearly 100%, or maybe 98, 97, 98%, but you're feeling all this weirdness of symptoms, and you're not sure something's wrong. You go to your doctor. Doctor also sees that, you know, but they let somebody do arterial blood gas, and they took a dive into it. They saw that you have, you know, not just low blood pressure, but let's say it wasn't low blood pressure at all. It might have been a different gas on there. You might have inhaled a gas in your home. You didn't even realize it. It's causing you a lot of problems. You could also be inhaling this on a routine basis, go into your home, but you haven't been checking your furnace to see if the pilot's out or something. Or there's a lot of reasons. It's not usually just one reason. There can be a combination of reasons why somebody would have low oxygen or even very high oxygen. But I get this a lot too. Somebody's exercising and is like, Alex, I get so out of breath. My oxygen looks so great. So does athletes. But some athletes, depending on the severity of the exercise, their oxygen will drop, sometimes even in the 70s. It doesn't mean they have a lung problem. It just means they worked aggressively hard on their exercise. They were probably sprinting, or they use a lot of muscle to do some type of accomplishment or some type of exercise or whatever, routine. So there's a lot of reasons behind it. Pulse oxes don't measure oxygen. If it was an oxygen analyzer, then look to spend around $15,000 on an oxygen analyzer, you know, depending on the oxygen analyzer. I know one's like around $15,000, but you don't need that. Pulse ox works just good, but it's going to assume oxygen. It's not an oxygen analyzer. I can't turn it on and just see how much oxygen is in the room I'm in. It doesn't do that. It assumes oxygen, okay? Hopefully the assumption is correct, right? But that's why you go into pulmonary rehab. We take care of that part for you, kind of educating you on what to do and things of that nature. Let's see, Dana, I got hospital rehab started last week. I've been doing all the stuff they were asked working at home. I have been doing a lot on my own, walking without my oxygen, pushing myself to get off the oxygen. Okay, but Dana, respiratory muscle training, are they doing the respiratory muscle training? And if they are, what type? Get back to me. I'd like to see that answer on here, Dana. Go forth. This is something that we see very often, that they're not incorporating respiratory muscle. A lot of places aren't incorporating respiratory muscle training, and that should be the standard. That was the old standards a long time ago, and as we've seen, anything a long time ago should get updated. You know, it should be. Just like some medications to some things that they discontinued were not looked at with the right people. Long story, but I'm not going to mention it. It's a long story. There are some clinicians out there that discontinued certain machines that were used very widely by respiratory therapists, and they're not used anymore because of one contraindication that us as clinicians don't have to work on that specific patient, but they discontinued the whole machine that worked on people with a different type of diagnosis, that worked very well with that diagnosis. So they discontinued those machines. And my point, I think you can kind of understand, is there are some drugs out there that they discontinued. There are some machines for clinical use that they discontinued for other reasons when they were widely used for a specific diagnosis, and they worked very well with a specific diagnosis. About and COPD medicine topics can't. I gotcha. Can we cure COPD? If there was a cure to COPD, pulmonary rehab would be the closest thing to it. Okay. Look, Melino, think of it like this. Are we increasing everyone's lung functions? In here, are we? Yeah, that's what we see all the time. So if we're increasing it, even if it was just a little bit, I mean, I could see that. Even if it was just a little bit, obviously that's not the case, but even if it was a little bit, how are you staying at the same diagnosis measurement level? You're not. So if you're improving, when are you getting worse? You're not. If you're improving, you're not getting worse. There's no third direction. So if you are improving, and you improve some more, and you improve a little bit more than that, and you improve a lot more than that, could that itself be what you can conceive as the cure? Sure, if you want to look at it that way, but I can't look at it that way. I cannot look at it that way. So yeah, you could look at it as, because you're not getting worse, you're improving. It would be different if you tried everything you can and you stayed the same. But if you're improving your lung functions, you're improving your volumes and everything, how are you getting worse? You're not. Breathing in, holding it, breathing out. They made me this, asked for a program, they gave me that. I asked for this program, they gave me that. Oh! So that's not respiratory muscle training, unfortunately, Dana. Respiratory muscle training is definitely, we can use, Delta Vs. There are other ones out there, but we use specifically Delta Vs for our rehab patients. And that's the reason why you see a lot of them walking when they only walked 100 feet, walked 100 feet, now able to do 2,200. While we're able to wean people off oxygen easily, while we're able to get people walking further easily, while we're able to get people's lung functions up easily, and why a lot of doctors, and I mean a lot of doctors in big-time facility hospitals in the United States use this specifically for the pulmonary rehab patients. We are the best. Okay? That's just the way it is. We are. We don't have to keep saying it, but we know we are. We are very good at what we do. We are the best we are the best in the business for pulmonary rehab. We've been around for quite some time now. We started up less than a decade ago, but we've been around and we've stuck. Insurance loves us. Everybody's loving us. We decreased hospital readmission rates. We increased people's lung functions. We get people to do things they weren't able to do. I have this video on here, and it might not mean a lot to you, but each and every patient that we see, each and every single patient we see, we as soon as they leave, we keep tabs on them, making sure that they stay out of the hospital, that they're doing everything they want to do. We got this. Let me see if I can grab this here. This is tech meeting. There we go. Let me see if I can add this in here. It'll be kind of hard for you to see it, but I'm going to see if I can bring it up. There we go. Let me see if I can bring this up really close. This was a patient that all she wanted to do was swim in a swimming pool. All she wanted. And she was able to do that. Oops, let me bring that down. She was able to do that. I know it's going to be hard to see it. But that's a patient that was not able to swim, and all she wanted to do was being able to swim again. And we got her up to swimming again. And at the comments at the end from our team was, I can't mention the name, but her name is Mary. I can't mention last names. But right down over here, it says, sent us this on Facebook. Sweet, this is her dream. You see that? This is her dream. A lot of people's dream is just to be able to go swimming, go on vacation again, being able to do things they weren't able to do. That's successful. That's successful. If you're trying to be in our rehab program, we do have about 52 more spaces for this month. So, and this month is almost ending, but we have 52 more spaces to get enrolled. All we would need is, and we do this for you, is we would communicate with your doctor, and we will get the referral that way. So you don't do anything besides. You just have to ask us to help you. That's it. And the easiest way to do is just call us or go online to homerehabnetwork.com and just fill out the you want to try to not come into class, but you just fill out a form on there. And if you don't know, just call the number on top. The staff back here will definitely help you with that to enroll you. If you have Medicare, and I do mean almost like nearly 100%, you're approved. if you have Medicare. If you have other insurances, yes, we just have to share with you what your insurance company will do and stuff. But all in all, if you have Medicare, and you have a secondary, you don't pay anything out of pocket. So yeah, we have a lot of insurance companies that takes us. The only one that's the hardest is Medicaid, is the tougher one. But I think everyone knows that. All right, so yeah, if you're trying to get into the rehab program, just go to our website. It'll tell you exactly how to get into our program. You can also call us. That's the 410-871-4601 number. Just call us up and we'll enroll you. But if you're trying to get into a rehab program, there's a chance of getting you better. We're one of the best shots there is. I'm not kidding. And everyone who's joined have never regretted it, have not regretted going into a good rehab program that has fixed their life up. That's all you guys need. You want that chance. We're giving you that chance. If you want to try to join in our rehab program, please do so. Okay? We do have quite a bit of space open for more people. Okay? All right, guys. Well, I believe, Judy, I believe so. I'm not a biller, but I believe TRICARE does. I just don't know because I'm not a biller. I specifically work for the pulmonary rehab side, but I do know Medicare, Aetna, Medicare, Blue Cross, Blue Shield. There's so many insurance companies that we take, but yeah, if all in all, if you sign up, we'll just check to see if your insurance takes you. It's not like I wouldn't worry about it, was what I'm trying to say. Because we contact your doctor and we see that you don't, that your insurance company, which I think TRICARE does, but I don't know. I don't want to give you a solid answer because I don't know. But we are covered by nearly every single insurance out there, so I think TRICARE is one of them, because I do recall TRICARE. But you want to give us a call and billing will look that up for you. I take 2 inhalers in the morning. How long should I wait between each? That's a good question. Usually, if you, depending on the inhalers, if you do the A, B, and C's, where the albuterol, Bactor, and corticosteroid, which are 3 inhalers altogether, take the first one, which is albuterol, wait 5 minutes, then take ipratropium bromide or tiotropium bromide. They're basically on the same category, the Bactor inhalers, and then take the corticosteroid last. Okay, if you can take them all at the same time, great. But if you have to take an albuterol, take that one first and at least wait 5 minutes. If you're only taking maintenance inhalers, then just take them as directed. But if you do have a bronchodilator, always take that one first. Okay, just to always take that one. If it's a bronchodilator by itself, always take that one first. A lot of corticosteroids also have a form of like alpha-motorol, which is a type of albuterol, but it's not used for short relief, quick relief. Quick reliefs are just specifically albuterol. Those are quick reliefs. If I do the hospital one, then maybe I can do yours. I have Medicare. Dana, if you do the hospital one, you can't do ours because you're only given a certain amount of Medicare. You only have a certain amount. So I believe it's 72 sessions in a lifetime. If you use up all your sessions in one place, you might not be able to go into another pulmonary rehab, even if you didn't gain a lot from your other pulmonary rehab. Insurance companies don't look at it like that. They're just saying if you joined or not. You have to make the educated decision on which one would work best for you, which one actually will get you the best outcomes and everything, and they have to go by that. They abide by that. As long as you're participating, even if it's a horrible one, you're still participating. Do you understand what I'm saying? So if you're not gaining a lot out of it, quantify it. How much have you been in the rehab program at the hospital? How much have they done for you? What have you learned? What are you able to do now? If you're seeing an improvement, keep going. But if you're not getting a lot of improvement, start looking somewhere else. That's the best advice I can give you. I will try something out. I have no problem trying something out because there are some good pulmonary rehabs out there. We just know we're the top one. But you go into a facility and you're not getting a lot out of it. You know, they're working you out, sure, but they're working out your legs, not your lungs. It's a different type of organ, completely different. And or let's say they're walking you, they're assisting you with medication, but they're not teaching you at least 20 different types of exercises. At least. We teach 1,700 in here. Why do you think everyone speaks very highly about us? It's like this old saying, somebody sees fire, right? It's an old saying, and I don't think I'm going to get the words correctly on this because I think I don't recall everything it said, but it's like you see fire, people will see it fire, but some people won't believe it's fire. They only believe it if it's burning them. Then they're like, oh, okay, yeah, that's hot, that's fire. What my point is that you have everybody right now telling you to join into a good rehab program, and you won't notice it until it burns you in the butt. You know, and you're like, okay, obviously this is not working. I have to research and go into a better rehab program because I found out that not all pulmonary rehabs are equal to each other. That's what I would say. I do my Brio, wait 30 minutes, and then Spiriva. Jerry, you don't have to do that. You don't have to wait 30 minutes for those. The albuterol is the only one that you should take first. Second one is a backdoor inhaler, corticosteroids last. If you wait 30 minutes, it's still not going to be completely wrong, but I think it's too much of an overkill, Jerry, to be honest with you. Pamela, you take 3? Okay, very good. But yeah, Dana, they won't give you unlimited sessions. They only give you 72. So if you use up all 72, they won't approve you for another rehab program. So just make an educated decision. You don't have to choose ours, but we just know what we can do. All right. I have aspergillosis fungus in both lungs. I'm 80 years old. Doctors put me on steroids. Is there any permanent solution? Please let me know. Vina, so my answer to that is we would have to see you as a patient. You would have to come in. It's all virtual. But we communicate with your doctor, we communicate with the hospitals, and of course obtain all the records that we need to make an educated decision on what to do. But all in all, we do this for a living. So we will rehab you, no problem, even if you're 80 years old. We have no problem doing that. Okay, and what I mean by rehab is complete rehabilitation. We will rehabilitate you. Okay. But we would need to know a little bit more, so we'd have to talk to you, not online like this. Okay, this is a certified facility. So we do have an inside facility where people can come in physically, but most of the patients, 99.9% of all of our patients, all do it virtually because they like they like to be able to be home to do their therapy instead of being inside a facility. They like the outcomes. They're able to do more now. They're more educated. They're doing a lot more walking. They're doing a lot more, they're improving greatly, So a lot of people just like the virtual one because it'll give them the same success rate as going into a traditional facility. And that's already been proven, not just by us. So just make a good decision on that. But Vina, we can help you with that. We just have to know. We would just have to talk to you. So if you go online and just let us know that you want to talk to us first, there's nothing wrong with doing that. I hope everyone knows that. You have the option to talk to us, no problem at all. We can just talk to you. Okay. Other than that, everybody, that's all the time we have. If you have any topics, which I haven't been seeing a lot of topics, but if you have any topics in mind that you would like me to address, please address them in the comment section. I'll be happy to make those rehab topics. All right, guys? I'll see you guys later. That is it.